Okay, so AFib. Okay, this rhythm, sawtooth waves, it can be irregular or irregular. There you go, A flutter. Okay, and that's the one, again. Okay, my drawing's not the best, but you get the message. Remember, in particular AFib as well as A flutter, you have lost your atrial kick. You now have decreased perfusion because of that, okay? People live with this. It is very important to control the rate, okay? Because the loss of the atrial kick is going to compromise perfusion. So rate must be controlled, okay? Some of you are like, are we going to talk about meds? I will bring out every med you need to know. Okay, you cannot go to a farm. You don't have time. Okay, so another very important aspect as a nurse, this is your number one reason for embolic stroke. Okay, these people are at high risk for clots. Okay, so you need to be thinking about those things. I already covered yesterday. You're also, the thinking nurse is looking at lab values, in particular potassium, sodium, calcium, magnesium. Okay, making sure those values are where they need to be. Okay, so those are important nursing aspects with these rhythms. Okay, this is the most common atrial dysrhythmia that you will see. And it's going to be more and more common as the population ages. And we're going to see more and more incidents of congestive heart failure, which is the number one cardiac diagnosis in this country. Okay, it costs the hospital billions and billions of dollars. Okay, so AFib, A flutter. Okay, this rhythm is sinus, and it may or may not be a problem. And the heart rate is less than 60. What is that? Sinus bradycardia. Again, okay, remember in your elite athletes, they have low heart rates. Jason, what's your heart rate? You work out all the time.
Probably around 75, 80.
Okay.
Elite athlete runs like
55? Yeah. Oh, yeah.
180.
Yeah, nursing school will do that too. Yeah, they'll just knock it right out the water on it. So, again, though, heart rate less than 60, sinus bradycardia. We'll talk, is it tomorrow? I don't know, I'll go over that. Today I'm doing EKG strip review. I've got practice strips, okay, and I want to see what you people can do if you feel the need to do that. This rhythm we do not treat unless the patient is symptomatic. Symptomatic being dizzy, cool, clammy, BP less than 95 systolic. Again, symptomatic is where we're going to treat this. Okay? This is sinus, but the heart rate, okay, y'all know what that looks like. Okay. This is sinus, but the heart rate is greater than 100.
Tachycardia. Sinus tachycardia.
Sinus tachycardia. Okay? May or may not be a problem. Again, when is it treated? With symptomatic issues arise. Okay? And this becomes a huge problem in patients who have cardiac disease. Their myocardium cannot handle increased rates. Okay? So as a nurse, if I know that patient has cardiac disease and their heart rate is 120, the first concern I have is get the rate down. Get that rate down. Because that's only going to compromise their perfusion. So again, if they're symptomatic, this is where we're going to treat. Okay? Remember, this is the rhythm. The heart, if you remember on that picture, it doesn't have enough time to get ready for that next beat. So that alone can compromise perfusion. Okay? So sinus tachycardia. Okay? This one, I described it as, a lot of my students in the past have referred to it as this. The tombstones. What is that? When you have sustained PVCs all in a row. VTAC. Remember, VTAC can actually be regular. It's usually at about a rate of 150. I got that 100 years ago when I had them. We actually drew them. I don't know. It was fun. And somebody drew it as a tombstone. It took the little thing there. So tombstones, sustained tombstones, VTAC. Remember, with this rhythm, you are to assess and see if that patient has a pulse. Why do I say that? You can have a pulse. Now, you're not going to have it long, but you can have a pulse. So you assess and see if they're pulseless. If they are pulseless, what do you need in that room? A defibrillator. That is what you want. Okay, is a defibrillator. You want to shock them out of that rhythm. Okay? This one is referred to as sudden death. AFib. Okay, this is the one. A lot of these patients die before they ever get to the hospital. Okay, that is why now you have your AEDs in these large populated areas. Because with the adult patient, they become pulseless. This is 9 times out of 10 they are in ventricular fibrillation. It's a very chaotic rhythm. Okay. If your patient is in VFib, they are pulseless, what do you need? Defibrillator. You need that defibrillator. Okay? Are you getting it? Reading strips is simply a skill. They get people off the side of the street and teach them. All they know is to read those strips. That's all they do, all day. I couldn't do it, no way, because I'm too into what it's doing to the patient. Okay. Okay, got that. Good. I was going to pick back up where we left off yesterday, and it's still I think it's EKG is what I named it, because there are would not be on your test, but just so you know, we can have premature complexes that are coming from the atria. This is called a premature atrial complex. You can see it's early. You can see it looks very similar to the normal complex. It's just early in the cycle. That is called a PAC, premature atrial complex. Okay, FYI, when would this be a concern? When you see them frequently. Why do I say that? If you start seeing these frequently, 9 times out of 10, your patient's getting ready to go into atrial fibrillation. Okay, so this is called a PAC. Okay, this is not on your test, but just so you know, if these start occurring frequently, they're probably going into AFib. You will not be tested on blocks. You're very lucky. Why do I even talk about blocks? Because there's stuff about pacemakers on the NCLEX test plan. And pace rhythm is also listed on the NCLEX test plan, okay? If any of you feel the need, probably right now you don't. And so I'm not even going there, okay? No, you got too much on your plate. Okay, so what happens to the myocardium, in particular, if you've got infarct? Remember that dead tissue, that necrosis on the right side of the heart. When it impacts the right coronary artery, that feeds into the SA and AV node. I can guarantee you those patients are going to have dysrhythmias. You're going to see a lot of funky stuff, okay? Not to say that you could not have it with an anterior myocardial infarction. In other words, you've got necrotic tissue on the left side of the heart, okay? That could happen too, especially because the LAD is going to feed into the SA node. So why is this a concern? This goes back to, if you're going to work with these strips all the time, you will spend time, if you're with me in clinical, we'll be measuring our PRIs and our QRSs. PRI interval, again, is the time that it takes the impulse to go from the atria just prior to ventricular contraction. And there's a time in seconds that we know is normal, okay? I gave you normal. Why? Because you could see a question on NCLEX about like a PRI interval being lengthened or a QRS interval being lengthened. You know, what meds or what action would the nurse take at that? So you could see a question like that on NCLEX. You could see a question like that on my exam, okay, if the PRI was long, lengthened. What would you question? Now, also medications could cause lengthening, meaning that the impulse is now taking longer to be transmitted, okay? So medications could do that, okay? Now, this block is called a first-degree AV block. In other words, the time from here to here is greater than 0.20 seconds. Okay? So it's greater than 0.20 seconds, meaning that should get your attention. that we need to be looking at the meds the patient's on, looking at their diagnosis, and seeing if this is something they've had or is it new. Okay? This may or may not be a problem for your patient. Okay? And if you come to me and say, Ms. Rummel, look, this PRI is lengthened. We've gone through everything. We've looked at labs. We've looked at their diagnosis. The one thing I'm going to say to you is watch that monitor. Why? Because this could be my first clue that my infarct on the right side is going to now go. I hate this thing. Hold on. To a block that is worse. So they could progress to a block that is now not only a delay from the time the impulse is traveled, that's moments. Now I'm seeing almost like a pattern. Lengthened. You see that? Lengthened. Look at it. It's like here. It's getting longer. It's getting longer. So in other words, this person's going to do something. Okay? They are going to a block that it's worse. This is called second degree block or Mobitz 1. Okay? And there's for some of you, again, just probably look at the slide. Mobitz 1, some of you may have heard it called Winky block. Again, when a block progresses from a first degree to a second degree, you need to give the doctor a heads up, okay? Because with my luck, they're going to progress even more, okay? Because a block can get worse, okay? It can go to now what is called second degree block type 2. And look at it now. Now I'm losing QRS complexes. Okay, as that block progresses down my conduction system. So now I'm actually losing QRS complexes, and that's called second degree AV block or Mobitz 2. Look at my rate. Just the rate alone should be like, uh-oh. And what should you be thinking? Somebody better get in here and put a temporary pacemaker in this patient. Or their perfusion's going in the toilet. Okay, so again, if a block progresses, then there's going to be trouble. You need a temporary pacemaker. For those of you that may say, well, how are you going to get a temporary pacemaker? You put a line in the jugular or the subclavian vein, and they'll take a pacing port, which is a piece of wire, and they're going to thread that baby down, and they're going to say, here, Suzanne, I hook it to my pacer, turn it on. Oh. Yay! That's what we ought to do. Yay! Okay, you can actually insert a temporary pacer port through a subclavian or jugular vein or femoral vein, but we don't like them in the femoral, okay? Now, religiously, my second degree blocks went to the worst, third degree. Third degree block is essentially man and woman, or woman and man are no longer married. P waves are doing their thing. QRSs are doing their thing. Okay? And guess what? Your patient is going to crump if somebody doesn't get a pacing port in there. Okay, so there is no marriage. They're just doing their own little thing. Okay, and that is third degree block. So again, why am I very, very concerned? Yes, we'll talk about the meds. But again, think about it. If my patient's got cardiac disease and just had a myocardial infarction, do I want to give them something that's going to raise their heart rate really high? No, that's only going to be temporary. This is a patient that needs a temporary pacer and probably a permanent pacer. But the temporary pacer allows me to have perfusion, or allows the patient to have perfusion, so they can then go on and get a permanent pacemaker. Okay? And a pace rhythm looks like you're looking for that spike. Okay? And when I get a spike that's initiating the ventricles to conduct, and see that spike is in front of everyone, that is called capture. And that is what I want. I want 100% capture. With a paced rhythm. Okay, because obviously that's going to increase my rate. Okay, so you want to see that spike in front of every QRS. The pacer's causing the ventricles to contract. Okay, so that is 100% capture. Okay, I'll reiterate that when we talk about the ICDs and more about pacers. Okay, there's one more rhythm that I want you to be aware of. Now, notice how narrow, this is not that wide and bizarre QRS complex. Actually, this is coming just below the AV node. So it is coming from the ventricles. But because it's very high in the ventricles is why you don't have that very wide and bizarre QRS complex. And we call this supraventricular tachycardia. Okay? You can have rates of 200 and 250. Supraventricular tachycardia. Okay? And when we talk about the meds, this is the one we're going to give a med, and it's called adenosine, and we actually are going to stop the conduction system. Okay? It literally stopped. You're going to see a straight line, and then it'll kick back in. So you want that straight line. Okay? It's really cool if you ever get to see it. We got to see it in IMC. It's really neat. I mean, because people are like, oh my God, you know. But adenosine. Now, I want you to tell me, because I don't want to, you know me, I'm very, there are meds that you need to know. meds that I'm thinking about just going over that now with the rhythms, and then I can reiterate that tomorrow when we talk more about code lab, okay? Because again, and then we're going to be moving to myocardial infarct. So that's what I'm thinking about doing. Just because we're so focused on the rhythms that I'm hoping you'll capture the meds a little better, and then I can reiterate that tomorrow. If you've noticed, I'm not trying to insult your intelligence in any way, but I have learned from working with my seniors, the more I can repeat something, the more I can go over something, the more they like it, so that they get it, okay? So take a break, okay? Go ahead and take 15